Carolyn. Thank you for the chance to join you at this amazing conference. I did not have the chance to be here yesterday, so I was privileged to hear the report outs this morning, and thank you for the gift of your summaries of what happened. But it was also a problem for me because I really don't have anything to offer. The ideas I heard were rich, many profound, and I literally can't find anything I prepared that you haven't heard before. So call this, I guess, a summary, and cut me some slack. I congratulate you for this work, and I want to congratulate the Gates Foundation. The interest of an organization of this importance and prestige in this topic of scale and getting change everywhere couldn't be overstated. If the Gates Foundation is interested and invests in this, that will change the world's attitude toward this problem, and I think it's an extremely important gift you're giving us simply by naming the problem, Gary. I have tremendous optimism listening today. Think of how much is going on, the energy behind this search for answers about how to get excellence to scale everywhere. Nobody has an answer yet, and I certainly don't. To me, it's a bit of a mystery. I had the privilege of working with Nana Chumdanso and the Ghana project before I took my current position. I remember traveling out to a tiny little clinic in a tiny little village, working on infant mortality, and on the wall of the clinic was what Jim referred to, the PDSA cycle, this model for improvement in this little village. Took 2 hours to drive there. I remember when I first saw that model in 1992 or 93, its author, Tom Nolan, came in my office. He said, you're not doing this properly, and he showed me how he thought a bit more about improvement. I know that he had gotten that idea from W. Edwards Deming. I know that it was Bland Godfrey, a friend, who introduced me to Tom. I know that Tom then worked with one of my staff to develop the Breakthrough Series project, which is the collaborative approach to improvement. I know that we happened to stumble on Pierre Barker of North Carolina, who was working on that. Pierre then took it over and started working in Africa. He convinced us to work in Africa. Along came Gates Foundation, or first the Health Foundation in England, asking us to find a country to work in. One of the countries surfaced was Ghana. Came Gates Foundation saying we'd like to try something to scale. My medical school roommate happened to know Nana and introduced me to her, so she's there. She goes to Ghana, starts the project, and the cascade of effects happens, and then on the wall of a clinic in a rural village is spread. It's the scaling of the meeting in 1992. It's a mystery to me. I don't understand it. It sounds so serendipitous, and we've got to somehow take this serendipity and either make lots of serendipity possible, or try to be more systematic. I don't have the answer, but I know the answers can be found. My experience here is both in developing countries and developed countries. I've worked with Joe McCannon and other colleagues in the Breakthrough Series projects, the 100,000 Lives campaign, the 5 Million Lives campaign in IHI. I've worked with Nana in Ghana and Pierre Barker in South Africa and many colleagues in Malawi. I've seen it. I have an impression, and I know this can sound arrogant if you think I don't know what I'm talking about, and you're probably right, but we really are in this together. I now run an organization that's supposed to provide a range for care for 130 million Americans. It's a massive undertaking. We are in real trouble in this country. The United States, healthcare is taking 17% of the GDP. It's taking resources from education and from roads and schools and museums and wallets of the communities. We have tremendous evidence of problems in that care. It's unsafe, not safe enough. It doesn't achieve its goals. It's certainly not worth the amount that we're spending on it in comparison to other countries that are spending a lot less. We have a problem, and now it's a macroeconomic problem. That is, American healthcare problems are connected to America's economic well-being, which is connected to global economic well-being. The stakes are very high. States in our country are reeling from the cost of Medicaid. The federal deficit is through the ceiling, and we're in crisis right now. There's a congressional committee, a special committee arranged to try to solve that, and if it doesn't solve it, there's a default across-the-board 2% cut called a sequester. We're really on a knife edge of trying to get to what we want and need. There are two ways to solve that problem here in this country, different from in the lower-income countries. One is to cut. We could solve the healthcare cost problem by just taking away things from people, cutting back on what we try to do, decreasing our ambition as a country, withdrawing benefits. The other way is the one we're all talking about today. That's improve. I deeply believe that improvement is a plausible way to make a system not just superb for the people it serves, but sustainable in the long haul. The improvement methods count. The problem is they only count at scale. We couldn't address the American healthcare problem, and we can't address infant mortality in Ghana or maternal mortality in Malawi or HIV/AIDS in South Africa without reaching total scale. That's the point. That's what counts. So the improvement problem we have cuts across the tremendous number of demands in the international frame, and it's what I'm dealing with it now every day. What is tantalizing to me is how possible it is. I travel a lot. I was in Denver a couple months ago, visited Denver Health. They've saved $100 million in their production of care simply by adopting Toyota production system methods to the healthcare context. Hard, but very plausible task. In Denver, I visited Clinic Campesina. Has a 32% increase in productivity of a very stressed workforce by using group visits. Group visits are a beautiful gem of an idea that leverage the time of people that give care. In Anchorage, Alaska, where I was a couple of weeks ago, I saw a telemedicine system to project specialty services out to all the villages, all the native villages in Alaska. They have 70,000 telemedicine visits this year, a return on investment in dollars of 10.54 to 1. And that's because a kid or an adult that gets help with an ENT consultation in an Alaska village doesn't have to fly to Anchorage to get that consultation. I've seen Seton Northwest hospitals in Austin, Texas, go almost 10,000 consecutive deliveries without a single birth injury. I've seen the ECHO project in New Mexico providing world-class now hepatitis C care throughout the entire state from a studio at the university. All of this can be done. It can only matter if it goes to scale. So we're in this together. Sometimes it works. That's what Joe was saying before. We really need to understand what works. A number of years ago, a young physician at University of Pittsburgh Medical Center, Rick Shannon, began working with ideas that frankly came from contacts with colleagues of mine at IHI around bundling interventions for prevention of infections of intravenous catheters in ICU patients. Just one man, one idea, working hard at that. Within a year, Shannon had shown a virtual elimination of an infection, a lethal infection that when I was trained in medicine, I thought was inevitable. Gone at University of Pittsburgh. That was, I believe, 1992 or 93 that work was underway. Last year, the Centers for Disease Control reported that between 2002 and 2009, there has been a 58% decline in central line bacteremia in the United States in all the ICUs in the country. So it can happen. We can see it happen. I want to show you an example, if I can cede some of my time to my colleague Rashad Massoud, who has a particularly interesting example. I just saw it this morning, and so I'm going to throw a little bit of curveball into the program, but if Rashad could just talk about those couple of slides for a minute, you'll see another example. Rashad, come. No. Right here. Light and sound.
What I'm showing here is a time series chart that comes from Niger. Niger, just for those who don't know, is ranked lowest on the UN Human Development Index. The x-axis on the chart is basically time in months. The y-axis on the left-hand side over here is compliance with an established high-impact intervention called the active management of the third stage of labor. And the blue line shows the degree of compliance. This is all or nothing compliance with 3 elements. And for those who don't know, it's the introduction of a drug called oxytocin at the 3rd stage of labor, controlled cord traction, and external uterine massage. This data is collected by the health workers themselves who conduct this work at the health center. Now, you can see that initially, we had very few cases where this would be done, and then all of a sudden, it starts to go up. The reasons why it wasn't being done were not because they didn't know, not because they didn't have the skill, not because they didn't have the drugs. It's a very simple reason. The drug, oxytocin, is thermally unstable. It has to be kept in a fridge. The fridge is in the pharmacy. The pharmacy, when deliveries happen at night, the pharmacy is closed. The pharmacist is at home, and the drug's not available. At the 3rd stage of labor, when the baby's head and right shoulder have just come out, when we need to use it, it's very difficult to get everything together in order to do it. So it virtually doesn't happen. Using improvement science, teams get together, they think through this, they come up with solutions. I'm just going to mention a couple. So some of them thought, can we get a cooler into the room? Others thought, can we pre-fill a syringe when we take a woman in to deliver her and put the oxytocin on an ice pack? As a result, you could see a high degree of compliance. Now, the red line with the axis being on the right-hand side, the y-axis on the right-hand side, that is postpartum hemorrhage. That is the #1 cause of deaths in women during childbirth. This data is for 28 out of the 33 health centers in the country, accounting for 1/3 of the births, and there are 3 years of data, 85,000 births. High impact at scale. It can be done in the poorest of contexts. Let me show you another graph. This is a very quick overview of a research study that we conducted. The collaborative ended, you can see on the top, it shows a line where the work ended. So we stopped providing technical assistance. We went in twice after that to look at the validity of the self-assessment data. And as you can see, it's pretty high continuing. This now is a similar graph where the team from Niger, this is our team from Niger, without any assistance from headquarters in Bethesda, started the same work in Mali, in a region called Kai region, one of the most remote and one of the most difficult. This data here is the same data. It's compliance with AMTSL and postpartum hemorrhage reduction as a result of that. This data, this work happened in just under 2 years. It's data for 41 sites, about 1,000 births a month. So this is about just over 20,000 births. And you can see very similar results. Again, very rapid, high impact results at scale.
So one thing is I don't want to leave any doubt that this can be done. Using a combination of the generative sciences that lead to the changes Rashad is spreading, and he's not alone, and the understandings we now have of complex systems and how they can respond, this can happen. To get there is going to require some changes. And what I've decided to do is to list for you a series of changes that I think might be called for in order to speed. And I've done this quite incorrectly as obstacles. These are toxins. I'm going to tell you what I think stands between us and doing this over and over and over again in a more reliable way and less serendipitously. The first toxin is to assume that incentives suffice. I don't know if this is a global health issue, but I know it is a problem in the US. There's a hegemonic view that if we change the incentives, everything else happens, and I will tell you that is not true. Incentive changes matter, but they are by far insufficient to achieve the kind of results Nana is talking about and Rashad's talking about. The second is the opposite, which is that teaching suffices. That somehow if when one is published, one is done. When one has published, one has not even really started. That is only what's on the shelf ready for bringing it to full scale. Incentives without teaching produce gaming. Teaching without incentives produce frustration. You need to understand the balance between the learning process and the motivation process. The third, Nana mentioned, is she said context is king. I wrote that down. It's insensitivity to local context is the mistake. All changes change before they're adopted. They change in the local setting. They have to. That happens with your tennis game and your knitting and your marriage and your cooking. You change it before you use it. That is always going to be the case, except for the most extreme examples of just installable technologies, which are few. The fourth toxin is evaluation. I can't think of anything that has slowed the progress of bringing things to scale more on the global scene than evaluation. This has to do with an impoverished view of what it means to learn as in action. Sequential evaluation is toxic to scale. Dynamic evaluation, something where learning is going on as we do the work, is a much more plausible and useful way to approach it. I differ with my colleagues here with great trepidation, but the concept that absolute certainty about the intervention is necessary before one brings it to scale, it must be forgotten. It is not true. And that is because interventions change as you bring them to scale. You never know where it's going to end up. And therefore, dynamic approaches to understanding what's going on are far more important than trying to be perfect at the start. All changes change before they're useful. The fifth toxin is to ignore tempo. In my work right now, heading CMS, we are really headed for a collision. If we can't figure out a way to help American healthcare improve its way to cost containment, we will cut our way to cost containment. And that is a race between two horses. And if one horse, the improvement horse, says, well, not yet, we're not quite sure enough, let's take our time, it's got to be nailed down, the other horse is going to win. I don't know what the same analogy is in the global health scene, but I can see it in Malawi or in Ghana, and that's that people are dying. There's a big human taxi meter running. And the leisure to say later is no longer, it doesn't seem quite right to me. And so a sense of tempo matters a ton. That is a little dissonant with the modern view of evaluation and learning. And so I just urge us to think about pace and tempo as perhaps more important than certainty. The sixth is, it's an unusual way to say it, but third-party learning is much less powerful than peer-to-peer learning. The secret behind what you saw Rashad present, or what I know, I'm talking about Rashad and Nanika, I know their work best, but I've seen this in many other contexts, including many of you in this room. It's when peers teach peers that spread through the early adopter and early majority parts of the change process really go. The seventh is that any single factor suffices. Distilling out changes so that you test them one at a time so you know which one works is an impoverished view of the ways to get to scale. It's really doing a lot. Now, I'm going to go a little farther, and I'm going to sound very irresponsible. One of the best healthcare systems in the entire world is in Jönköping, Sweden. I know it because I've worked with it for many, many years. Jönköping is a county southwest of Stockholm, 300,000 people or so, and for reasons I don't have time to explain, it has gelled around improvement as a strategy. I've gone there many times, I've taught there and listened, and I asked one of the leaders in Jönköping a few years ago, how are you doing this? And he said, well, everything changed when we realized the secret. And I said, what's the secret? He said, the secret is do everything. That, by the way, is why I'm so optimistic, because there's so much going on. The unleashing of changes, the unleashing of the palette of efforts is what counts. Jönköping, Sweden finds anything it could possibly use, and it uses it right away. There's nothing sequential about the approach. The eighth toxin is overemphasis on central control. Telling really doesn't help. That violates even what we know about adult learning theory. Pull beats push every time. And so the projects that I think work best set in place frameworks. They set visionary, I hope very exciting goals, like do no harm. And that's relentless. They help with data. They help so the local units kind of know what's going on. They import ideas. They arrange for the peer-to-peer context. There's a lot of arranging going on. But the change itself and the power lies in the local setting. They're the ones who know best what to do. And in the end, you can't tell them to do anything. You can set the table for them to use what you have. And then it is Haja Mary Iska or Sister Angela out there in a local clinic who says, I think I get it, and begins the work of real change in the local setting. The last point has to do with a comment one of you made today, I think it was Dr. Deering, about operational guidelines. Joe McCannon picked this up in terms of logistics. I once heard the phrase, this was from a person actually in the military, who used the phrase, strategies for amateurs, logistics is for professionals. That has to do with that local context issue. It has to do with the actual deeds that are done, the systems of support, and the the arranging that has to go on in order to make change possible. Now that's a limited list, but it gives you some idea of what I think I've heard from you and what I believe. What's next? First, Gates Foundation, all of you, I think you're on a great road if you can continue to give this field dignity. That if you can move forward the concept that this issue of how to take excellence to scale, how to promise every human being on the planet that they will have access to the best we know, that changes the game. So please don't let up on that. The second has to do with evaluation methods. I don't mean to be at all insulting about this, but I will tell you that without a new palette of evaluation tools that are very responsive to local settings, fast tempo, local learning, and constantly formative knowledge, we probably will continue to step on our own feet here. We'll trip over each other because we just need a new framework. It's emerging. The Yale model is very helpful with that, I'm seeing around the country, around the world, beginning to grapple with this issue, but I think we could use a lot more momentum around how to learn as we evaluate. I guess my last idea is now let's make it real. I think we will learn more. The next conference will do more. If it were possible, I guess I'll say it simply, to decide to spread something. To begin to talk about a set of 4 or 5 important areas of improvement where we kind of know the stocks are full, we kind of know what to do, and say the planet will now be covered. We will make it our business to do everything we can to build the knowledge and momentum to actually save those lives at full scale. We would learn a ton by doing that. I even have a way to think about this. I think it'd be done 3 times. I think there's a set of these to do, which I would call the spreading of organizational forms. The example I've got is local here in the US. We're trying to build coordinated care systems in the United States. We have a very uncoordinated care system, and the idea of coordinated care has emerged. And I think we're now at the point as a country, I see it from the CMS point of view, where we actually could nurture coordinated care organizations in every city in the country. That would be kind of a 10-fold project, 10 times the numbers of organizations capable of doing something that's important in the global health scene. Then there's a 100-fold task, which you saw Rashad give an example of. That would be bringing to 2 orders of magnitude of spread some programs that delight us, that are really effective, where we know what to do, and the problem is they're just not around, you know. And you can see, I've seen that happen in the global health context. I think we could do it. And then there's the 10,000 level, which has to do with reaching, with the topic of this conference, reaching individuals. We could dig into that more. But nothing beats specificity at this point. I think if we could set a goal with the help of this foundation and others and just go for it, then we'd be talking about the realities of what we're meeting out there in the field. Those are some comments. I apologize for just repeating a lot of what you've already said. The word I'll leave with is optimism. Think of the energy. Think of how many different people are now grappling with this very important problem. That's got to spell success. Thank you very much.